presumably I don't need to tell you much about the Centre for Mental Health today. Okay, very good. So we're an independent charity. We've been around for just under 30 years. And our role is really about research that changes people's lives by looking at how we can create a fairer chance in life for people with mental health problems. So we're deliberately not a provider of services. What we do is help build up the evidence, look at what research says, and look at how we can improve the game of services up and down the country to really create a fairer chance in our society for people who happen to have poor mental health. So I was set an essay question talking about equality of opportunity, and what I've tried to do is kind of crystallise some of the research that we've done and others have done in some areas that I think are really important, and hopefully in the discussion part we can see where that goes. Of course, the obvious things to say first of all, following Time to Change, is actually the first thing you've got to do is tackle stigma and discrimination. And I think it's really powerful what Time to Change are doing, and I worked at the centre prior to when we had Time to Change, and we were desperately struggling to engage more broadly, whereas now I think we've got a real opportunity and a real voice in the world, and thank goodness we have, and what a fantastic initiative that is. So really all power to Mind and Rethink Mental Illness for making that happen. Okay, so on with the stuff. This is where we are today. If you happen to have a mental health problem, your life is likely to be poorer, shorter and harder than it should be, and it will be for anybody else. And we know that people with mental health problems, first of all, and this of course is really fundamental, have high levels of unmet need. So 3/4 of people with a mental health problem get no treatment and support at all, or indeed recognition for it. So already you've got a very large proportion of the population who are quietly suffering, very significant effect on quality of life, and yet getting no help and support at all from formal services. We also know, particularly with people with more ongoing mental health problems, very much less likely to be in work, that children with mental health problems, particularly behavioural problems, do much worse in school. So already these are the big things that affect our lives and the quality of life and the chance we have in the world out there. But we also know people with mental health problems face a greater risk of being victimised, of being victims particularly of violent crime. We also know there are very high rates, of course, of poor mental health in the prison population and the offending population. I think what we're beginning to understand is that people with mental health problems also have poorer physical health, and the two go together. They don't sit separately in our lives. Who'd have thought? And indeed, if you have a mental health problem, you die younger than you would if you didn't. And particularly for people with severe mental illness, the mortality gap is so huge and so dramatic that it has to be a focus for any effort around equality. So that's really grim news just before lunch. The good news is that there are things we can do about this. It doesn't have to be this way. There are a whole load of interventions, many of them very simple, very cheap, certainly by comparison to some of the stuff we do in the NHS, that it's incredibly good value for money and we need to invest in and support. And so hopefully in 10 or so years' time, we'll see some of these inequalities beginning to come down or coming down significantly. That would be great, wouldn't it? So, what can services do? And particularly I'm thinking about mental health services here, but actually it's a whole range of public services we know need to engage with mental health and people with mental health problems more effectively. First of all, because we have all that unmet need, fundamentally we need to make more interventions that work available to more people. Some of the things I'll talk about later, some of the things you know, some of the things you're working in services doing are not available to enough people at the moment. So we need to be doing things at a higher volume. We need to be offering support earlier. It's one of those things that's almost a truism across mental health in almost any area, that the earlier you intervene, obviously there's a humanitarian case for doing that, people are suffering for less time, but also it tends to mean that the recovery is more successful, the person's life is less badly affected by the mental illness and society's attitudes towards it, and it can prevent a whole bunch of later problems, all of which are incredibly costly for the individual, for their family, and indeed for a whole range of services. I think we also know from now growing evidence that the role of services should be much more about supporting a person's individual recovery on their own terms. It's not about having a service that does this thing and it puts people in and it gets them out the other end. It's about every single person having a very individual journey through building a life for themselves. And I think something that perhaps services are beginning to learn to do, but from a very low base, is also going out there into the community and engaging with local schools, with employers, with people just in ordinary day-to-day life. Mental health services have tended to be rather closed in this rather special environment. And indeed, if anyone works in a communication role in a mental health trust, you'll know very often the job is about fending off bad publicity, the fear of what happens if something awful happens, and what if the local paper gets hold of this. Many will have suffered kind of campaigns to stop a facility opening in a neighbourhood. And that's a tremendously difficult place to come from. But I think we have to engage and be more outward. And crucially, we also have to tackle inequalities within mental health. We talk a lot, and I'm sure there's been a lot of mention already today, about parity for mental health with physical health. And that's absolutely right, and we should be going for that. We also have to recognise that within mental health, we have huge disparities ourselves between different groups, between different areas of need, and we have to also get our own house in order, I think. So that's some of the areas I'm going to try and rush through in the next however many minutes Sean's given me. So first of all, a focus on recovery, because this is where a lot of the work that we've been doing, and we've been doing with a lot of organisations that are working in mental health, and a real partnership to really understand what mental health care is all about, which I think increasingly is understood as supporting an individual to build a life for themselves on their own terms, with or without the symptoms of mental illness. Not assuming that we can have a one-size-fits-all approach where the focus is on control, containment, coercion, curing, and then somehow worrying about the rest of things happening in a person's life. The key elements we know from a growing amount of experience for what recovery feels like, if you like, is these three things. Hope, a belief that the future can be better. Control, both over your life and how you live it, and also the treatment you're receiving for your condition. And opportunities for a life to do stuff outside illness. Very few of us growing up thinking, well, what I want to be is a user of mental health services when I grow up. We want to be pilots, train drivers, all these other things. And it's about allowing people to have the same aspiration, the same expectation that anyone else would have in our society. Okay. Through a project that we've been doing by the name of IMROC, Implementing Recovery Through Organisational Change, which I think we've now worked with around about half of NHS mental health trusts in England on, and some in other parts of the UK as well. We've learnt an enormous amount over the last few years about what a recovery-oriented service looks like at the organisational level. We know what it looks like at the individual level, but what about overall in the service as a whole? And these are some of the features that you tend to see and that tend to encourage a more recovery-oriented approach. First, and perhaps foremost of these, is a bigger role for peer support. People who have used or are still using services, supporting others, being part of the workforce, being there, offering a sense of hope and belief for the future. Also, of course, having opportunities themselves to become workers and support others. And I think crucially, this notion of co-production. It's a challenging notion for some, but actually it goes through the system. So if you're commissioning a mental health service and you haven't got people who are using that service as part of the conversation, not being told this is what you're going to get, what do you think, but actually being part of the decision-making process for what services should look like in the future, I don't think that's what modern commissioning looks like. It has to be as a partnership between GPs and the new clinical commissioning groups and the people who are using the services they're commissioning. Has to be a real change there. Many who work in mental health services are now getting interested in this idea of recovery colleges. And in fact, when I talk to colleagues at the latest count, there are now 30 of these up and down the country, which is really exciting. If you don't know what a recovery college is, go take a look at one. But they're fundamentally about creating an environment in which people can learn and which professionals, service users, family members and others can come together for learning opportunities, for teaching opportunities, and really to, again, build that sense of hope and opportunity for the future. Really exciting places, and they have a transformative effect on the whole culture of a service. And that's why they're important and exciting and inspiring. It needn't be said really, but safety on inpatient wards is still a major issue out there. And if you don't have a safe environment when you're first admitted to hospital in what can be a terrifying experience, how can you hope to build recovery and equality of opportunity? Really fundamentally important, very, very difficult. But again, the No Force First initiative and many others that are going on at the moment are beginning to show a positive way, and you can create a safer environment. And of course, involving peer supporters as well in creating a safer environment. So it all goes together. Help with employment and housing, and indeed welfare advice I'll come back to. But I do want to focus on support for carers, family and friends. We recently produced a briefing paper on this. And it is a challenging area for mental health services, but many services still don't know how many people that they're working with have family carers involved, know what the needs of those family carers are, let alone have involved those family carers in decisions and thinking about what recovery looks like for the individual service user. This has to be part and parcel of it. It can't be separate. Just to look at some of the areas in detail. And I guess one area of equality of opportunity that comes up time and again, and so it should, is employment. And as of today, less than 1 in 10 people using mental health services have any kind of paid work. For some groups of people, the figure is much lower again. And we know that around about half from CQC surveys, probably more, would like the chance to work. So there's a huge discrepancy there. It's a very, very big one. And the frustration here is there is a technology available or an approach available called individual placement and support, which we know gets very high success rates in supporting people into employment. And while it doesn't work for absolutely everybody who goes through it, the idea that it's somehow available in some places and not others, I think we should regard as a scandal. Given the effect of employment on supporting recovery, if this was a medicine that had the same effects that IPS had and it was available in around about half the country and not another half, that would be unacceptable. So why is it that IPS is only in certain places and not others? We really need to start expanding it and looking at where the gaps are. We're beginning to do a bit of work at the centre in supporting some areas where it's poorly available at the moment, and we're hoping to do that a bit more. But again, if you don't have an IPS service where you are, please have a think about that. Come and talk to us, and we can help with that process. We're also testing it more widely now, including in primary care for the first time. Very exciting area of development. We'll report back on how that goes. Here are some of the features of IPS if you don't know what it is. First of all, nobody's excluded from it. This notion of employability, or you're not ready for work, is not part of IPS. If someone wants to work and wants to give it a try, they're ready. They might need a lot of support, but they're ready if they want to work. And no compulsion. Now, this is challenging in an environment where we have benefit sanctions and the work programme and conditionality and all that stuff coming from DWP's world. But what we know from the evidence is when you compel people to go on programmes and do this and do that and do the other, it doesn't work. It's fundamentally about voluntary participation without exclusion. It's also about rapidly getting people into jobs, not waiting and doing lots of training and voluntary work and all the other things which might be very good, but in a sense they tend to hold people back from actually taking the step into employment. It's finding out what someone's good at, what they like, going out and finding jobs for people in the local economy, real jobs, and then supporting people intensively when they get them. And that again is fundamentally important. I think just following up the question previously about employment and support within work, a real help to this is the Access to Work scheme. And I don't know how many people here are aware of Access to Work, but it's a fantastic scheme. It's money from government, believe it or not, to support people to make reasonable adjustments in workplaces. In terms of the last figures, around about 3% of Access to Work funding was for people with mental health problems to get and keep work. And yet we know it has huge potential, for example, to cover when you need time off, to provide alternative transport to work, to provide advice and support for the employee and employer. Really exciting scheme. It's free money. Go use it, go find out about it if you don't know about it. It's a really great thing, I think. Just to give you an example of an IPS service, one we know very well, is Southdown in Sussex. It works with the entire trust there, so the 2 counties plus Brighton and Hove. They've got a team of 22 employment specialists who work across the county. They're all embedded in clinical teams. They're not separate, they're not a different thing. They're part of the clinical teams. And last year, they worked with about 1,200 people and helped a quarter of those into employment during that 1 year. And that, when you compare it to the rates of employment that we know pertain over the country as a whole, is pretty impressive. It's one of many services that are now around, but again, they're always very open and keen to show what they do. So if you want to find out about it, go take a look. Another area I think is less well understood and less well thought about, but it's fundamental to equality, is housing. And this comes really from two ways. First of all, insecure housing is a huge contributor to mental ill health, particularly among children. Children growing up in an insecure environment, in housing where they're not sure where they're going to live, in temporary accommodation, have very much inflated rates of poor mental health throughout their lives. But also, good housing is a fundamental part of recovery from mental illness. Particularly if you've been in an institution a long time, you've been in prison, you've been in a hospital. Having somewhere to live, having somewhere you feel safe, that meets your needs, is fundamental to recovery. And we know that things like floating support, the old Supporting People programme, sadly not as earmarked as it once was. Really, really sad that has gone by the wayside in many places. But again, support for people to maintain tenancies, to be at home, to be independent. It's as much an important part of mental health care as anything else that the services are doing, and yet it's really being given very little attention, something we want to put right over the next couple of years. More recently, we've looked at the value of welfare advice, and this may sound remarkably obvious, but it clearly isn't in the way services are working. That people using mental health services have very high rates of a whole range of welfare issues, debt being the obvious one. There's a huge relationship between debt and poor mental health. And yet we know in most parts of the country, expert welfare advice isn't there within the mental health service. It's not part of the core offer, and it really should be. We looked at a Citizens Advice Bureau that works within Sheffield Mental Health Trust. It's actually part of the Trust service. It's commissioned by the Trust, in fact. And what we're able to do, looking at the economics of this, is if you compare the cost of the intervention, the advice on welfare issues, with the price of someone becoming unwell, staying longer in hospital, losing their home potentially, relapsing into psychosis maybe if they become unwell and it becomes a trigger, there's just a huge discrepancy. And again, it's a fantastic value for money intervention as well as being really good for people's lives. So have a think about welfare advice if it's not part and parcel of the service you're involved in. Better physical health is an area that, again, Brian was here earlier, Rethink Mental Illness have had a really major campaign on. And it's incredibly important, and it has to be regarded, I think, as part of recovery. That actually, if you're suffering from poor physical health, you're not getting help with smoking, the medications that you're being given are causing you appalling physical side effects and taking years off your life, that's not a recovery-oriented service. That's a service that's failing a very fundamental, basic need of a human being. And we need to make sure we're doing much, much better around that. What we also know, tracking back a little bit, is that early intervention is incredibly effective. And there's a whole range of early interventions in mental health. I've listed a few here, but if you think about the importance of mental health during and after pregnancy, and the importance of supporting women to provide them with the help they need, particularly before birth, when people are very vulnerable, and actually many women who have postnatal depression tend to have problems before, and yet by and large services are not picking these needs up. We also know that many people using mental health services shock horror are parents themselves. Who'd have thought? And yet how much support are we offering to people with their parenting responsibilities and that role in their life? And we know there are fantastic things like parenting programs now available that can particularly help people with young children and that have a big effect on their children's life chances themselves, so intergenerational stuff. Whole bunch of other early interventions which I shan't bore you with because I'm coming to the end of my time and lunch will not be far away. However, another area I think we do need to think about, they're just a few little random thoughts now. Timely response when needed. This is, again, remarkably obvious, and I think it's a hallmark of what parity looks like, actually. That we need to start getting better at providing services in the places where people want them, when people want them. It's really great that we're going to have the first national standards now for access to psychological therapies and early intervention in psychosis. And that's a really welcome development, but it has to be the beginning of the story. We need, over a period of time, over the next Parliament, to ensure that access to mental health care in a timely manner is as normal as getting an operation within 18 weeks or being seen in A&E within 4 hours. This is not difficult stuff. It's incredibly difficult to do, but as a principle, it has to be the basis, the underpinning of how we organise things. So if you have a crisis, you get dignified, decent treatment, and preferably a choice of how you're treated, no matter what your emergency is, whether it's psychological or physical, that we have liaison and diversion services in police custody and in courts, getting around about to the point where we'll have half of England covered now. That's very exciting, but we've got to finish the job. And we need mental health teams in general hospitals too. And in all those cases, for all those things, this pertains to all ages. Children, adults of working age, and in later life as well. It's not okay just to do it for some mental health service users. On which topic? I think we have to, as I said, get real about the inequalities we still face within the system. Race equality was a big focus between 2005 and 2010, wasn't it, with the Delivering Race Equality programme. There hasn't been very much since as a national policy priority. We've got to get that right. And again, we've got to look across all age groups at how we're promoting race equality within mental health. What's happening in childhood? What's happening in schools? What's happening that particularly young African and Caribbean men and women are coming into contact with the mental health system through police intervention, not getting support from primary care? How is it that that journey is happening in so many places and so many lives? And can we begin to intervene a bit earlier to try and tackle some of those issues? Age equalities, obviously there's particular issues around disinvestment in children's mental health, around the still very, very poor response to later life mental health, but also, of course, those transition points between those different services. Many, many groups of people are poorly served. Do we really yet have good quality care for people with personality disorder, people with dual diagnosis? Probably not. Maybe in some places. Maybe there are some really good models that we need to learn from and pull out and do a bit better across the piece. And disability equality is an area that I think, you look at people who have a whole range of disabilities, learning disabilities and physical disabilities and sensory disabilities. Are we offering a quality of mental health care for those groups? In many places we're not. And one final little thing to bend your ear about. Let's start this at home. The mental health of the NHS workforce is not the best looked after, is it? NHS organisations should be leading by example in being good employers of people with mental health problems. And I'm not really sure that that is yet happening, yet alone the opportunity to then do that and then ensure it's happening within the supply chain. Think of the organisations that get their business off the NHS, who could, for example, be encouraged to be mindful employers. Wonderful scheme, Mindful Employer, do take a look at it. Who could be encouraged to be positively hiring people with mental health problems rather than just simply carrying on as normal. Last of all, local leadership, really exciting. And an initiative that we're involved in with other national charities is called the Mental Health Challenge. And this is all about encouraging local councillors to champion mental health in their local areas. We now have 35, they're all absolutely wonderful. They're all elected members, they come from different parties and different political persuasions, different parts of the country. But what unites them is a passion for mental health and a passion for political leadership. You've seen political leadership nationally with Luciana Berger and Norman Lamb and all those others. And yes, there are issues about how far that's going, but we need it locally as well. So if you don't have a council member champion in your area, or indeed if you are a councillor and you're not yet a member champion, do not leave without talking to me. And let's see if we can get a few more and encourage them to really change the way the conversation is happening in each local area and speaking up for mental health in a very different way to what we've had before. That was a rather breathless go through, a whole bunch of issues. We haven't got very long for conversation, so